My job now is as the Medical Director for Clinical Effectiveness in NHS England, but when I first worked there, my role was around reducing premature mortality. And my job now is actually simply the same job, only broader. But when I first started as Director of Reducing Premature Mortality, I had to think what were the areas that were most important to focus on. And people were already looking at cardiovascular disease and diabetes and cancer. And I said, well, coming from a background as a surgeon in the acute hospital and as someone who sadly caused enough sepsis in my time, I think sepsis is something that's well worth working on, and therefore we've been able to take that forward. So, this is interesting. We seem to be a bit short of slides. Never mind. So first of all, why sepsis? Well, you've heard why sepsis. We know that it's important both individually and for the population and economically. And I set up a sepsis programme board, which was really just a coalition of the willing. And we've brought together people from different parts of the NHS who have a particular interest in improving sepsis. So we're working with NHS Digital, who are doing some work to improve the coding for sepsis. We're liaising with NICE because apart from the guideline that's come out, they're planning to develop a quality standard on sepsis. We're encouraging some work on safety netting, which is something that the bereaved families who lost young children from sepsis are particularly keen for us to do. And the big GP software systems, EMIS and System 1, both have built systems that GPs can use for safety netting when they see parents with children with infections. You've heard about some of the other work with some of the Royal Colleges. I'll just say the Royal College of GPs is focusing on sepsis this year. The Royal College of Physicians is updating the work on news. We have Health Education England that's producing educational materials. And we've recently named 2 national clinical expert advisors on sepsis, which many of you will already know, Dr. Matinada Kim in the south and Dr. Emmanuel Sutebu in the north. Both of them are in the acute medicine infectious disease arena and are supporting us on our work. Bruce Keogh has launched the professional awareness campaign on sepsis, which is around Think Sepsis, which is very much in parallel with the PHE work that Ron described that has been done with the UK Sepsis Trust on public awareness. And the Secretary of State has a direct interest. So how does this come into the CQUINs? Well, we were fortunate that we were able to get sepsis on the list of CQUINs from 2015. For those who aren't completely aware already, these are payments which are made in order to improve the quality of care in trusts. The way they've been set up, it's not additional money, it's contract money which you only get if you meet certain quality criteria. And there are good examples of where they've been able to bring variation up to a very high, consistent standard. And a good example of that is the work a few years ago on venous thromboembolism. Prophylaxis was very, very patchy for hospital inpatients, and people were dying of pulmonary emboli. And the CQUIN was absolutely instrumental in getting everybody to a situation in the trusts where people were given prophylaxis systematically, and it certainly reduced mortality from that condition. So the sepsis CQUIN, well, it started in the year 2015-16. It initially focused on the emergency department only. That was because at that stage we were still very concerned that we weren't defining sepsis very effectively, and we felt it would be easier to start in ED because it was a single department of the hospital, and also because the College of Emergency Medicine, now the Royal College of Emergency Medicine, had previously done 2 rounds of audit on treatment for sepsis in that context. So when we set up that first CQUIN, it was about using the National Early Warning Score or similar to identify the people who were particularly unwell, to assess those people for sepsis, and if sepsis was found, to give antibiotics promptly as part of the Sepsis 6 approach. We deliberately did not list all the items of the Sepsis 6. We just felt that would make for very bureaucratic measurement, and so we only measured the antibiotic aspect of that. And it was a sampling data collection with some exclusions. And I think it's fair to say some people found some difficulty with that, and we have amended the sampling approach since then. So how did it do that first year? Well, all the data from the sepsis CQUINs is available on the NHS England website. We're hoping to make it available going forward on fingertips as well, just to make it that little bit more accessible, and it is on a trust-by-trust basis. So in 2015-16, in emergencies departments, between the start of the year and the end of the year, the rate of people being checked appropriately for sepsis rose from 52% to 78%, a really, really significant improvement. And in the people who were found to have sepsis, the rate of prompt antibiotic administration went up to 49% to 62%. So a good first year. And we were able to continue the CQUIN into the following year. And I'll just show you the data from that for EDs. No, we're having, okay. So in the EDs, the data collection continued, but we were able to add the deteriorating inpatients as well. And we also wanted to make sure we were starting to align with the work on antimicrobial resistance. So we added the 3-day review of antibiotic prescribing. And as I say, I think we improved the sampling methodology. So looking just at emergency departments in 16-17, the assessment for screening increased further. So in the last 3-month period, we're up to now 85% being screened for sepsis in a timely way. And timely treatment increased to 62%. Now, that's only the same as it was at the end of the 15-16 year. But remember, this measurement around timely treatment includes the 3-day review. So we made it more difficult to achieve the standard for timely treatment by adding the 3-day review to check if people were on the appropriate antibiotic. What about inpatients? Well, for inpatients, we've only been measuring since the start of 16-17. It was 62% in the first quarter, 69% in the second quarter, so that's going in the right direction, and timely treatment was at 64% in the second quarter. So going in the right direction, but I think you'll agree still not where we need to be. So there's more work to be done to improve the timely treatment. The competition to get CQUINs onto the books for 17-18 and 18-19 was even more intense, because we knew it was going to be a 2-year program, not a 1-year program this time, and we knew that there was no additional money available. And we were very, very pleased that working with our colleagues who were doing the work on antimicrobial resistance, we were able to get a joint CQUIN covering the 2 topics and bringing them into one, which we feel was a really important thing to do, because we believe the same teams should be working on sepsis and on antimicrobial resistance. They're 2 sides of the same coin, and we want people to think of them in the same context. We know it's about the right person getting the right antibiotic at the right time. So, from the first 18 months of the CQUINs, just from the sampling data that we've got, which, as you know, small numbers of patients from individual hospitals, we reckon that approximately 550 lives have been saved just in those samples in the hospital's data that came in. So that's a really good start, and one can extrapolate that up to potentially significant numbers if all patients in hospitals are getting the same level of prompt recognition and treatment. We've said that we're moving to this start, smart, and then focus approach by joining with AMR, and hospitals are also expected to have a local policy which fits with national guidance on which antibiotics to use, and to make sure that all people who are treated with IV antibiotics have an appropriate review within 3 days to make sure they're on the right treatment. So I think it's quite symbolic to have sepsis featuring so prominently in this conference on infection prevention and control. I completely endorse what has been said earlier about the importance of prevention in a variety of areas, but I think prompt recognition and prompt treatment are absolutely key to helping reduce mortality as well. Thank you very much.